Here's a summary of the latest insights and treatments related to diabetic retinopathy. Pathophysiology. Hyperglycemia-induced damage. Chronic high blood sugar levels in diabetes cause damage to the small blood vessels in the retina. This leads to leakage, bleeding, and the formation of abnormal new blood vessels. Stages. 1. Non-proliferative diabetic retinopathy (NPDR). Early stage characterized by microaneurysms, retinal hemorrhages, and macular edema. There is no new blood vessel growth. 2. Proliferative diabetic retinopathy (PDR). Advanced stage with the proliferation of new, fragile blood vessels on the retina and into the vitreous humor, which can cause severe vision problems. Risk factors. Duration of diabetes. The longer a person has diabetes, the higher the risk. Poor blood sugar control. Uncontrolled diabetes significantly increases the risk of retinopathy. Hypertension and hyperlipidemia. These conditions can exacerbate the progression of diabetic retinopathy. Pregnancy. Pregnant women with diabetes may experience accelerated retinopathy. Symptoms. Early stages. Often asymptomatic. Patients might not notice any changes in vision. Advanced stages. Symptoms may include blurred vision, floaters, dark spots, or even sudden vision loss. Latest treatments and management. 1. Anti-VEGF therapy. Medications: ranibizumab, Lucentis, aflibercept, Eylea, and bevacizumab Avastin are commonly used to block vascular endothelial growth factor, VEGF, reducing new blood vessel formation and macular edema. Efficacy: these injections have become the first-line treatment for both diabetic macular edema (DME) and PDR, showing significant improvement in vision outcomes. 2. Laser photocoagulation, focal grid laser, used for treating DME by sealing leaking blood vessels. Panretinal photocoagulation, PRP, used in PDR to shrink abnormal blood vessels and prevent further bleeding. Though still relevant, PRP is being used less frequently with the advent of anti-VEGF therapy. 3. Corticosteroids, intravitreal injections. Dexamethasone implants, Ozurdex, and fluocinolone acetonide, Iluvien, are used for DME, especially in cases not responsive to anti-VEGF. Side effects. Potential risks include cataract formation and increased intraocular pressure. 4. Surgical options, vitrectomy, used in cases of vitreous hemorrhage or retinal detachment due to PDR. The surgery involves removing the vitreous gel and sometimes replacing it with a saline solution or gas bubble. Number 5. Blood sugar control, glycemic control. Intensive management of blood glucose levels through diet, exercise, and medications, including insulin, remains the cornerstone of preventing the progression of diabetic retinopathy. Emerging therapies. Research into novel agents like fenofibrate for lipid control and anti-inflammatory drugs continues to explore additional preventive strategies. 6. Telemedicine and AI. Screening advances. AI-powered retinal imaging and telemedicine platforms are being increasingly used for early detection and monitoring of diabetic retinopathy, particularly in underserved areas. Prevention and monitoring. Regular eye exams. Annual comprehensive dilated eye exams are recommended for all diabetics to catch retinopathy early. Blood pressure and lipid management. Keeping blood pressure and cholesterol levels in check helps in reducing the risk of retinopathy progression. Patient education. Educating patients on the importance of regular monitoring and controlling diabetes is crucial. Latest research. Gene therapy. Experimental treatments targeting genetic factors involved in retinopathy are under investigation. Neuroprotective agents. Researchers are exploring drugs that protect retinal neurons from damage, potentially offering new treatment avenues. Overall, early detection and the integration of advanced treatments like anti-VEGF therapy, combined with strict metabolic control, are key to managing diabetic retinopathy and preserving vision.